Hello everyone, welcome back to another class on regeneration biology, and in today's class we will learn about artificial liver, kidney and urinary bladder used for transplantation in patients. And we'll also see how tweaking of the scenario can help in fixing a damaged or almost close to complete damage. So damaged in the sense not complete damage, close to complete damage also can be recovered. So an overview of artificial organs means including artificial livers, kidneys and various other organs are used to support patients with organ failure, often act as a bridge to transplantation or until the body recovers. So that is the whole purpose. Sometimes your organ has the potential to bounce back, and the concept of artificial organ is not they are terminally ill. That situation also is there when the liver is beyond recovery or kidney is beyond recovery, then naturally you need a transplantation. But sometimes you are derooting it or you are taking the show in your hand. So this is also a artificial way of sustaining the organism. While artificial bladders are not yet as advanced, although some case studies of transplantation has been done, they are being explored for patients with the urinary dysfunction. So let us see some examples. Artificial liver systems, the purpose of artificial liver system like molecular adsorbent recirculating system MARS, one option that assists liver functions, particularly in patients with acute liver failure or acute or chronic liver failure. So they can adopt this technique, that is they can have a MARS available for fixing their damaged organ function. These systems remove toxins from the body and may help with the liver regeneration or bridge to transplantation. So before the transplantation ready, the organism should recover. But if the liver is not functioning, then the organism is not ideal for even a transplantation, even if liver is available. So in that scenario, this kind of support system becomes very helpful. Some examples like MARS, that is single pass albumin dialysis, that is called SPAD, and bioartificial livers known as BALs. They use various methods including adsorption, filtration and cell-based systems to mimic the liver function. So this is basically to uplift the organ and also the organism itself. So benefits of artificial liver system, they can improve liver function, stabilize the patients and potentially bridge them to transplantation or recovery. Sometimes you need a transplantation despite all these efforts. Sometimes they will recover back. Same way, artificial kidney systems, the purpose of artificial kidney system like those used in dialysis are well established treatment for end stage kidney disease. They are applied in those scenarios where the filtration doesn't happen in the body. So the functioning of this system, they filter the waste products and excess fluid from the blood, mimicking the functions of the healthy kidney. So benefits is the dialysis can support the patients with the kidney failure until a kidney transplant becomes available or their kidney function improves. So these are all the support system. And same way, the urinary bladder also people use it, that while not widely developed as an artificial liver or kidney, artificial bladders are being explored for patients with a severe urinary dysfunction. The function of these include the devices will help with urine storage and for emptying, offering an alternative traditional bladder management techniques. And the examples include some research focuses on using bioengineered bladders or other devices to restore the bladder function. So the benefits include the artificial bladders could significantly improve quality of life of individuals with a severe bladder dysfunction, because bladder, if it is not functioning properly, it is not just a bladder's problem, it is a problem with the kidney also. The pressure or the regulation functioning of the bladder is not fine, then your kidney is going to get affected very badly in short duration. Although their kidney is perfectly fine, the bladder is the culprit to cause the damage to the kidney. The important considerations to be taken care of is the bridge to transplantation. Artificial organ systems can act as a bridge to transplantation, allowing patients to wait for a donor organ while their condition is managed. And the limitations include artificial organ systems have limitations, including potential complications and need for long-term management. Because you cannot, people cannot live on dialysis forever, and it's cumbersome, too costly. But sometimes you have to stabilize the patient so that they are available for the transplantation or other operative procedures. The ongoing research continues to improve the effectiveness and safety of artificial organ system with ongoing efforts to develop more robust and biocompatible devices. So now let us see a status update on artificial organs. Where do we stand? Artificial organs are engineered devices that can be implanted or integrated into the living body to replace a failing organ or to duplicate or augment one or multiple functions of the deceased organ. The development and optimization of artificial organ has progressed tremendously throughout the past 75 years to include fully implantable and biocompatible devices and materials. We have seen many examples include putting a heart valve or putting a aortic tube, etc. There are so many such examples are existing. So they are all artificial organs that is been put in. The first device feature which we examine is the mobility, and here, as with other properties also, the technologies span a range from the entirely stationary situation, that is, for one example include the hemodialysis, to a fully mobile situation, that is artificial kidney. If you want to do a hemodialysis, you cannot roam around and do it. Whereas if you have an artificial kidney, then it will do the job. You can roam around and do whatever you want, your day-to-day life. So it doesn't restrict you to a hospital life. Just even if it is for few hours, it will become a cumbersome process for some people. But for others, if you have an artificial organ implanted, then they can do their routine thing. The second device feature is the biocompatibility, or the capacity of native tissue to tolerate the implant without rejection or thromboembolism sufficiently. Sometimes when you put an artificial thing, organ or tissue, anything artificial, it can trigger a thromboembolism. That means you can get clotting, and sometimes big clots will be formed which can block your coronary arteries. It's a very serious thing. So at time doctors will give blood thinning agents, etc. But this has to be taken serious care of. The third technological feature is synthetic organ functionality, and devices exist as a continuum from the partial, that is, for example, artificial pancreas, to full, that is, total artificial heart, for example, functionality. So these are all the approaches that is being taken care of for designing a artificial organ. The fourth range of device properties spans from artificial devices composed entirely of synthetic materials to biodegradable structures that integrate native tissue into functional performance. That means you are making a artificial versus natural, or artificial plus natural, a hybrid organ. That means it has both artificial and natural thing, and you can't distinguish between both of them. These mechanical and functional differences provide the framework through which we explore the current status and future possibilities of abdominal and thoracic artificial organs, because they are the major organs that are waiting for artificial organ. You don't care too much about artificial bone or artificial, of course they are important organs, but they are not always a life-threatening scenario. A list of organs are listed here, like the status, current and future. So It can be artificial organs, features and capabilities, present and future when you compare. It has to be fully compatible, and current status none, and future, for example, a pacemaker may come which is fully compatible, and fully implantable, one status report, that is a pacemaker, current it is available, and in future you can have artificial pancreas and various other organs that can come, that is come in a fully implantable scenario. Intracorporeal with external components, and many examples are there. Current scenario, artificial pancreas, but future we may end up getting an artificial kidney, so on and so forth. So many organs are available in a usable scenario right now, but not all of them are mobile. Many of them are very static and cumbersome, so which limits the patient's movement. Let us see some examples. Artificial liver by culture and cell transplantation. Acute liver failure. So far we have seen is artificial organ support. Now we are thinking about, can we have some organoid, etc., that is been used. Acute liver failure is a high mortality syndrome. In short form it is referred to as ALF, for which liver transplantation is considered the only effective option in case of acute liver failure. A shortage of donor organs, high costs of the surgical procedure, and surgical complications associated with the immune rejection of the transplanted organ constrain the therapeutic effects of liver transplantation, because that is heterologous. Whoever is donating, you cannot donate your liver to yourself. If it is an organ transplantation, it can come from only genetically similar or a closer individuals. Recently, the mesenchymal stem cells MSCs therapy was recognized as an alternative strategy for liver transplantation, where the damaged liver is restored to a better situation and you are providing the MSCs, mesenchymal stem cells, so that they can help in fixing the damaged liver. You may remember when we studied the ethics, the fetal stem cells fixed a mother's liver problem. So that means stem cells have the potential to fix a existing liver problem, as serious problem as that required a transplantation. So that was that Boston case study which we discussed. You can go back and see those who want to revisit. Bone marrow mesenchymal stem cells have been used in clinical trials of several liver diseases due to their ease of acquisition. Very easy to get it. No one will have difficulty in getting bone marrow stem cell from any person. Strong proliferation ability, multipotent differentiation, homing to the lesion site. Homing, we saw in the previous class that the stem cell should be able to go and recognize the damaged organ. Stem cells do have that ability, but they should respond to the chemokines coming from the injured site. And low immunogenicity and anti-inflammatory and anti-fibrotic effects are seen from this hematopoietic stem cell or bone marrow stem cells that are used effectively for fixing the liver problem. Homing and immunoregulation of MSCs triggered by the injured liver. So in this picture, we should know, if a liver is injured, what are the cytokines and chemokines that are released, which will be sensed by the MSCs or bone marrow stem cells, BMSCs, which you are putting into the liver, which help in fixing the damaged liver. Hepatocyte transplantation has been considered as an alternative to organ transplantation, but has been hampered by the lack of large cell quantities, expansion difficulties ex vivo, rejection of allografts and xenotransplantation, and the rapid loss of liver properties in vitro is been seen. So that is why the hepatocyte transplantation is a very good option, because when you have an option of delivering hepatocyte to a damaged liver, life becomes more easy than just giving stem cells. Stem cells including fetal, biliary, tree stem cells, fetal liver stem cells, and hematopoietic stem cell, endothelial progenitor cells, MSCs, induced pluripotent stem cells, and others can transdifferentiate into hepatocyte-like cells, to restore the damaged liver and response to stimulation. Mesenchymal stem cell therapy has been extensively studied and it shows a great clinical promise due to its ease of acquisition, strong proliferation ability, multi-potential differentiation ability, homing to the lesion site, low immunogenicity, and anti-inflammatory and anti-fibrotic effects have helped this approach to go in. This is a picture that shows after damage what are the changes that is occurring to various cell types: mesenchymal stem cells, sinusoidal endothelial cells, injured hepatocytes. They are all been shown in different color. And what is important is after damage there will be too much of metalloproteases and also interleukin 6 and various pro-inflammatory cytokines will be released from the injury site, which has to be sensed by these mesenchymal stem cells or hepatocytes what you are artificially putting from outside, so that they can go and fix in a place where there is a damage. So this is how the approach is done. Multipotent differentiation and functions of the mesenchymal stem cells derived from various tissues. So this picture shows that MSCs are a heterogeneous population that can adhere to plastic and proliferate. They can proliferate ex vivo. They can form colonies with the fibroblast-like morphology. They can differentiate into any cell type, that is osteocytes, chondrocytes, adipocytes, and other mesodermal lineages, and have endoplasmic and endodermic and ectodermic differentiation potential exist in them. Means they are MSCs are quite robust in that way. As you can see in this picture, that MSCs can give rise to mesoderm cells, endoderm cells, and ectoderm cells, etc. Several studies have shown that MSCs can differentiate into functional hepatocytes and cholangiocytes after growth factor induction ex vivo. That means in a outside the organism. Intrasplenic transplantation of human-derived BMS, bone marrow stem cell BMSCs, into mice with fulminant liver failure. That means the mice model is having liver failure and they have been treated with a BMSC cell that is isolated from human, and with the hepatocytes and the immune cells. So they are humanized in the sense these mice, although mice liver is damaged, it will not reject these human cells because it is a humanized mice. And a recent investigation reported that MSCs can also self-assemble to three-dimensional, that is 3D, human liver ex vivo by transdifferentiating into hepatocytes, sinusoidal endothelial cells, and hepatic stellate cells. So it can give rise to many cell types present in the liver. Hence, transplanting MSCs or BMSCs will be a good approach to fix the damaged liver. So this is an example of different tissues can be used: placenta, umbilical cord, bone marrow, adipose tissue, etc. for making mesenchymal stem cells. So now let us see acute kidney injury for a therapy, prospects and challenges. Acute kidney injury, AKI, is a heterogeneous syndrome comprising of diverse etiologies of kidney insults that result in a high mortality and morbidity that is not, if not probably managed. Although great efforts have been made to investigate the underlying pathogenic mechanisms of AKI, there are limited therapeutic strategies available. Extracellular vesicles are membrane-bound vesicles secreted by various cell types, which can serve as a cell-free therapy by transferring bioactive molecules. EVs can be isolated from your bloodstream itself. They are vesicles, extracellular vesicles that can be used for treatment. EVs in AKI with a high therapeutic potential, which could be subdivided into stem cell and non-stem cell derived EVs. So, yet several challenges and opportunities related to the clinical translation of animal studies exist. That means you can pick up EVs from a stem cell and deliver into an organism's so that its damaged organ can get fixed. So if you see an overview of this, by clinical definition, acute kidney injury is a syndrome of kidney damage resulting in a rapid decline in renal function and a decrease in the urine amount, or both can be together. It is widely recognized that AKI is associated with an increased risk of morbidity and mortality. So this is a cartoon of EV, that is extracellular vesicle, and that can be isolated, and you can do a multi-omic analysis to understand the contents of these EVs, and this therapeutic application for the fixing of the kidney by delivering these EVs onto the damaged organism or the organ or present in the organism. So EV sources for human therapeutic uses. EVs are non-replicating phospholipid bilayer membrane-bound vesicles that are secreted by the cells. EVs can be isolated from the bodily fluids such as blood, plasma, serum, urine, milk, cerebrospinal fluid, etc. and released from in vitro cultured cells also. They can be released. Blood is particularly rich in EVs and is easily obtained. Thus, plasma, serum, blood, platelet-derived EVs have been widely investigated as biomarkers and therapeutics in AKI to understand the AKI and other diseases. EVs derived from hearts of post-myocardial infarction contain pro-inflammatory cargo naturally, because those EVs will have, because myocardial infarction triggers an inflammatory response, which exacerbated the injury in recipient mice, and donor age is also reflected in EV cargo and function. So if the EV is from an old person versus a young person, it will be reflected. So you pick the ideal EVs and deliver to the damaged organs. Since EVs have rich and complex cargo consisting of hundreds of different bioactives, microRNA, proteins, lipids, and they can act simultaneously on multiple pathways in different target cells which AKI can impact. For example, during ischemia or reperfusion induced AKI, there is a hypoxic and metabolic mitochondrial injury plus additional necrosis and apoptosis of the TECs due to the trapping of the erythrocytes and subsequent toxicity. The major mechanisms of EV's action relevant to AKI therapy include the acute protection of the parenchymal cells of the kidney, reducing their apoptosis, stimulation of their proliferation, modulation of inflammation, reduce the inflammation by these delivered EVs, and immune cell recruitment, promotion of the endothelial cell angiogenesis, and modulation of matrix remodeling and fibrosis by fibroblasts. So this can be fixed so that the ongoing damage can be controlled. So EV delivery and uptake by the kidneys. To manifest their activity, the classically designed mechanism is that EVs must reach the target site, interact with the desired cell membrane, and then deliver their cargo, what is present in the EV, in sufficient concentration to alter the cell responses to injury trajectory. So the precise mechanism of EV uptake and cargo delivery are very complex. In brief, there is evidence that EVs can fuse with the target cell membrane, delivering cargo directly into the cytoplasm, or they can bind cell surface ligands and they can get endocytosed, at which point they may fuse with the endosomal membrane and deliver the cargo into the cytoplasm, or they can be subjected to degradation or recycling as well. So cells such as macrophages, key players in response to AKI, are also capable of engulfing by the phagocytosing of the EVs itself. Lastly, there is evidence that EVs can stimulate intracellular pathways by binding cell surface proteins without the need for internalization. They can do that, acting onto the cell surface proteins as well. Thus, assessing the delivery is a complex issue, and the most studies take the whole organ approach, and they do not specifically measure extracellular or intracellular compartments. Cell-specific uptake or organelle-specific uptake is good enough for fixing the damaged organ when you are doing a EV treatment. There's a schematic diagram showing the isolation of the therapeutic cell-derived EVs and their cargo. So you can isolate the EVs from the cells, centrifugation, EVs are there. You deliver onto the damaged organ, and then you expect uptake and activity, EVs can get in and you end up getting a recovery. So multiple mechanisms of EV activity is been studied in a kidney tubular epithelial cells are mentioned here in this picture, including the endocytosis, membrane fusion, etc. So indirect activity via macrophage polarization also is possible in the case of EV, and EVs can also be probably engineered also in future. So the reported mechanism of the therapeutic action are what is based on the available evidence, but its future is enormous potential exists. So tissue engineer autologous bladders. Now we understand the urinary bladder for patients that is needing cytoplasty is possible. That we saw liver, we saw kidney, and now we are looking into the bladder. Patients with end-stage bladder disease can be treated with cytoplasty using gastrointestinal segments, that is the existing options. Such segments in the urinary tract have been associated with many complications. Although it can be done, but it also have many complications. So the researchers have explored an alternative approach using autologous engineered bladder tissues for reconstruction. So the urothelial and muscle cells were grown in culture and seeded on a biodegradable bladder-shaped scaffold made up of collagen or a composite of collagen and polyglycolic acid, PGA. And about 7 weeks after biopsy, the autologous engineered bladder constructs were used for the reconstruction and which is implanted. So the engineered bladder tissues created with autologous cells seeded on collagen polyglycolic acid scaffolds. It's a combination of both. One is artificial, one is natural. Collagen is natural, polyglycolic acid is artificial. Can be used effectively in patients who need cytoplasty. So that means you are creating a bladder in a external outside the body. Those who are interested can read this Lancet paper. So this is a picture from the same paper, the construction of engineered bladder. You can see here scaffold seeded with cells in A and engineered bladder anastomosed to the native bladder with running 4 to 0 glycolytic structures in B, and the implant covered with fibrin, glue and omentum is seen in C, which is ready for transplantation. And to summarize what we know is a major challenge in engineering tissues or organs for clinical use has been to develop biodegradable three-dimensional constructs that can accommodate adequate amounts of cells for functional tissue formation, without which the organ production will not stand in its intactness. The scaffold should have the appropriate biomechanical and structural properties to preserve tissue integrity for a long term. You don't want an organ to be working for 5 years or 3 years. You want it for rest of the life of the person. Using a composite scaffold composed of PGA, polyglycolic acid, which supports structural integrity, and the next component of scaffold is collagen, which supports cell growth and survival, proved optimal for bladder tissue engineering, as we saw in this paper. Another challenge for engineering tissues and organs that involves the need for constructs to be sufficiently vascularized to support and maintain this transplanted cells, means the angiogenesis. Although the cells are being formed, urinary bladder is a less complex tissue, but that doesn't mean that it do not need blood supply. So tissue engineering techniques can generate bladders implanted in patients that is requiring cytoplasty. That means it is a very serious condition. Although follow-up of longer than 5 years is reported in these transplanted patients, additional studies will be needed before this procedure can be used widely. But in principle, bladder transplantation is a big success, but more studies need to be done to understand the exact effectiveness for every patient. So organ culture, organ transplantation is a vast field. We cannot cover all of them in a short time. Those who are interested can read more articles. We will study more in next class. Thank you.